You're live.
Good evening, everyone. Welcome to our Focus Online, Lecture 249, Squint and Pediatric Ophthalmology Session 36, and an exam special as well as a Diwali special. So happy Diwali to all of you. And today we have with us Dr. Shubhangi Bhave, ma'am, and Dr. Varada Gokhale, ma'am. And today is the OSCE in Strabismus. And also we have with us 15 to 17 enthusiastic students from JNMC Belagavi who have volunteered to be a part of the session at the hot seat. So Dr. Shubhangi Bhave, ma'am, has been a part of GMC Nagpur alumnus for the past 37 years. And she has various publications and is a recognized postgraduate teacher by Nagpur University. Ma'am has been a president of Nagpur Academy of Ophthalmology, president Vidarbha Ophthalmic Society, and scientific committee chairman of OSCE, member of scientific committee MOS, and life member of various ophthalmic societies. And she's been practicing at Drishti Eye Clinic since 1994. Dr. Varada Gokhale, ma'am, has been a student of JNMC Savangi, Nasik, and has finished her post-graduation from and fellowship in Pediatric Ophthalmology and Strabismus from Shankar Nethralaya, Chennai. She is currently the medical director of Madhav Nethralaya Eye Institute and Research Center, Nagpur, and has presented her work at Young Researchers Research Award sessions and various national and international colloquiums, and has published in reputed journals. Welcome to both of you, ma'am, and thanks a lot for sparing your time on such a special day for the postgraduates.
Thank you so much. Happy Diwali to all of you.
I focus Dr. Santosh Unawar for asking us to conduct this program. And just a word to all my young students who have joined this program, that just take it as a fun thing. Don't be disheartened if you can't answer a question. This is just an incentive that you need to study the subject even more. And so we've not kept any marks. So we'll just go, we'll ask the question to each. And I think first we will ask one basic round to the first year students, and then the clinical round to the seniors, and then diagnostic round again to the first years, and management round to the seniors. So this is how we've done. And you'll have 15 seconds to answer the first question, and subsequent questions, it should be 5 seconds. Is that okay, Rolika?
Yes, ma'am. Sure, ma'am.
Is that okay? Santosh sir?
Yeah, perfect.
Yeah. Yes, ma'am.
So this is going to be a fun because Squint is always a little confusing. So we'll have good interactive sessions so that if you have any doubts, you can ask also. So it's not like a proper quiz where we are going to find out a winner, but it will be a short course of pediatric ophthalmologist and Squint, which we are going to discuss over 60 minutes now.
Sure, ma'am.
Shall we start?
Yes, ma'am. You can share the screen, ma'am, or would you like me to share the screen?
I'll share it from here.
Okay. Sure, ma'am. Anything.
So shall I call out the name of the student who is going to answer first?
Yes.
Okay. So first question goes to Anu.
We'll keep the sequence which you have written, na Varda?
But the first 5 are final year, ma'am. So we'll start with number 6.
Start with 6. Okay. Yes.
Ma'am, you can make start the slide share so that it comes in full screen.
Okay, so we've put some effects. Varda has nicely put some effects of crackers so that to give a festive feel to this quizzing. So we start with quizzing. Coming to the basic round, the first question goes to Anu. For a smooth movement of the eye in one direction, the agonist muscle must contract and antagonist muscle must relax. Name this law of motility. Anu, you have 15 seconds to answer. You can say pass if you don't know the answer. Anu?
Anu, would you like to answer? If anybody else would like to answer?
Sherrington's law.
Say it again.
Sherrington's law.
Sherrington's law.
Yeah.
Ma'am, her answer was Sherrington's law, ma'am. Ma'am, can you hear me? So I think ma'am's video is paused. Okay, so we'll go ahead till ma'am joins again. So could you name two conditions in which the law fails? Anu, could you answer that too? Just a second, I'll share the slide.
What did she say? I couldn't hear it completely.
Ma'am, actually your video got disconnected. So I'll do one thing. I'll share the slide here.
Okay.
Right? Just a second, ma'am.
Yes.
Yeah. So you can see that, ma'am?
No, I can't. Now I can see, yes.
Okay, okay. Ma'am,
Yeah.
she answered Sherrington's law, which I believe is
The right
correct.
answer.
Yeah.
So the second question is, name two conditions in which this law doesn't act or law fails. Answer quickly. We don't have a lot of time.
You have 5 seconds for each question. So you have to be faster. This is OSCE, so it has to be spontaneous.
Yeah.
It has to be spontaneous.
Yes.
Duens retraction syndrome.
Yes, retraction. Yes.
What did you say? Duan's retraction and?
Okay, ma'am, we can move on to the next question. So we can wait for
Yes.
5 seconds for everything.
What is the yoke muscle for right medial rectus? Can't hear them. Is she answering? I can't hear what she's saying.
Ma'am, I think should I answer on behalf?
Yeah.
Left lateral rectus.
Very good.
Left.
Very good.
Yes. Left lateral rectus, she said, na? And name the contralateral antagonist muscle of right inferior oblique. Name the contralateral antagonist of right inferior oblique.
Left superior rectus.
Yes. Okay. So, Varda, can you just give the answers?
Yeah.
Next slide.
So the answer is the law of motility is Sherrington's law of reciprocal innervation. Can you change the slide, please? The two conditions where the law fails is Duen's retraction syndrome and aberrant regeneration of third nerve. The third question is, what is the yoke muscle for right medial rectus? Is left lateral rectus. And the last is contralateral. Actually, this should be a synergist muscle for the right inferior oblique muscle, that is left superior rectus. If we talk about contralateral antagonist, it will be left inferior rectus. Okay, so the diagram shows the yoke muscles and the synergistic muscle. So how I remember for Sherrington's law and Herring's law is S for S, that is S for the same eye. So I used to remember that same eye will have two muscles. One will be acting agonist and one will be antagonist. Okay.
Next question. Next question is, which test gives such responses within 10-15 seconds? Zeal can answer. Zeal can answer.
Ma'am, there was some problem with their audio. Ma'am, we can ask somebody else till then.
Okay, Ashita. Ashita, can you answer? In fact, I'm not seeing anything on my screen there, the participants. Just a minute.
If they can switch on their videos, it will be good.
Okay, so if everyone switches on the videos and we can see more number of questions, otherwise it will be like, you guys are missing on some questions, right? So
Ashita,
what?
can you answer? Unmute yourself and answer. Which test gives such responses?
Ashita, you can unmute, yeah. You're not audible. Okay, Surumi, would you like to answer?
Word for dot test.
Yes. What does this test measure?
Assessing the binocular function.
Yes. In the presence of squint, if the person says he can see 4 dots, what does it mean?
It's normal.
In the presence of squint, if the person says he can see 4 dots, what does it mean? I think 5 seconds are up. If a patient says he can see 3 dots, what does it mean?
I don't know.
Okay. So, Varda, can you just, next slide, please?
So I'll just tell you quickly about Worth. This is Worth 4-dot test. It should be done for distance as well as for near. And this does measure the binocular vision, that we put a red in front of the right eye and green glass in front of the left eye. And we ask the patient to read how many dots are there. So if patient has squint and still he is saying there are 4 dots, that means there is something abnormal. The abnormality is abnormal retinal correspondence in one eye. So ideally with a squint, either one eye will be suppressed and he should get 2 red or 3 green, but still he's saying 4. That means there is abnormal retinal correspondence. And the answer for the 4th question is, if the patient sees 3 green dots, that means he has right eye suppression. That is the easiest question probably.
Next slide. So we're going to the 3rd question on the basic round. Which are these glasses? And what are these glasses used for? Quickly. Don't need 20. No
Sweekriti,
need.
you can switch your screen on.
Sweekriti,
Sweekriti, quickly, please.
which are these glasses used for? What are these?
Mona wants to answer, ma'am.
Yes, please answer. Please answer.
Okay, Yesha, would you like to answer?
So we go to the next question. Can anyone answer?
Bagolini class.
So these are the Bagolinis. What is the angle of striations? Quickly again. What are the angle of striations on these glasses? Okay.
45 degrees.
45. Both are 45.
135.
Correct.
So one is on one eye, 45, on one eye, 135. So they make an angle of, they cross each other and make an angle of 180. What is the advantage of this test?
Lesser dissociative effect.
Least dissociative. If the cross is seen with a central blank in one eye, what does it mean? You see a cross response, normal, but if you see a blank on one eye, what does it mean?
Ma'am, I think we can go ahead with the answer.
Yes.
Fine. So correctly said, this is the Bagolini's glasses, which are used for checking binocular single vision again. So the striations are like 45 in one eye and 135 degrees in the other eye. The advantage is, yes, correctly said, it is the least dissociating test in all test available for checking binocular single vision. And the last question is, if there is a central suppression in between, and in between the cross in one eye, that means there is central suppression of the right eye. See here, you can see the right eye, there is central scotoma. So this can happen in a very small angle squint. We also call this as monofixation syndrome. Okay, so normal response is a cross with a central dot.
So next question. So we go to the fourth question. Who will be answering this? Anyone can answer, those who can know.
Muskan, you can switch it on. and
Muskan.
answer.
Okay. Which charts are these? Which are these charts?
Muskan, this is an easy question. You can do this.
ETDRS?
Huh?
Not ETDRS.
Not similar.
More
Huh?
logmark.
Yes. What is the difference between the lines? What is the difference between these lines? Okay. Where are they used? Where do we use these charts? Muskan, where do we use these charts? You try something. Okay. 660 on Snellen's is equal to what on Logmar chart? 6 by 60 on Snellen's is used to what on Logmar chart? If we need to compare. Yes?
1.
Yes?
Correct.
That's good. Yeah.
1. Yes. So just Varda, give the answers. Next question, please. Next slide, please.
That's really great, Muskan. Good attempt. So this is a logma chart. So the difference between the two lines is usually half octave, that is 0.1 log units. And they are mainly used for academic and research purposes. They are little modified than Snellen's charts. So nowadays we are also using logma chart in our OPDs. And 616 Snellen's is equal to 1 on logma. You correctly answer it. So well done.
So next question on the basic round.
Yeah, that would be Reshma answering.
Reshma, could you answer? Please put it on. Now you can, yes, have you put it on your audio?
Yes,
Yes, ma'am.
Yeah. So this patient has an esotropic appearance, but if you do a cover test, there is no movement on the cover test. Which condition could this be? Reshma, which condition could this be?
Pseudo strabismus.
Yes, very good. Name 2 conditions which can cause this appearance of an ESO deviation without any squint. Name 2 conditions. Yes.
Where does pseudo-strabismus occur? In which cases?
Okay, we'll go to the next. What is angle kappa? What is angle kappa? Yes. Angle, okay. And which refractive error causes a negative angle kappa?
High myopic.
A high myopia. Very good.
Okay.
So I think we'll go to the answers.
Yeah, so the first question, this is a pseudostrabismus. Most commonly seen in high myopia, uriblepharon, and also in children with broad nasal bridge. The angle kappa, most commonly asked question. This is the angle between the visual axis and the pupillary axis. Everyone should know this. And the negative angle kappa is caused by high myopia. Well attempted, Dr. Reshma. We go to the next question.
So we go to, who will be answering next? Kirti?
Yes, ma'am.
Okay. So we go to the 6th question on the basic round. You are seeing certain symbols. What do these symbols indicate, Dr. Kirti?
Nystagmus.
Yes, very good. What is PAN? Not your PAN card. What is PAN in terms of nystagmus? Yes.
Try to think.
Anyone? Yes.
N stands for nystagmus for sure.
Yes. You
So
have to just guess the two earlier alphabets. Yes. Okay. Name two compensatory mechanisms adopted in this condition. Two compensatory mechanisms which the patient adopts
Face turn.
in this condition, not in PAN, but in nystagmus.
Face turn.
Yes, very good. Anything else? Anything else to dampen nystagmus?
Convergence.
Yes, very good. And name one surgical procedure which is done for this condition. Name one surgical procedure which is done to correct maybe the face turn or whatever. Yes.
this I think they might not know.
Okay, okay. So just go to the answers.
So the diagrams represent the nystagmus. So the line with an arrow is mainly for the amplitude. You increase the horizontal line that increase the amplitude, that is fine, moderate, and gross, as shown in the figure. The frequency is number of arrows put on the end of the arrow. So that is tail end of the arrow. That is, one arrow is slow, moderate is double, and faster you can represent by 3 tail end arrows. And if it is curved, so that means it is the rotatory component is also there along with the horizontal one. So this is the way how we represent nystagmus with amplitude, frequency, or if there is any rotatory movement. So second is what is PAN, correctly answered. That is not answered actually. So that is periodic alternating nystagmus. In this nystagmus, the eye beats at one point in the left gaze. It stands still and again start beating in the left gaze. So there is alternate change in the direction of nystagmus. This is usually seen in cerebellar diseases, and patient may have oscillopsia. So what we do to reduce this disturbance, visual disturbance because of nystagmus, patient will turn their face in one direction. This is the answer for the third question. So they will have a compensatory head posture, and they can also converge to dampen the nystagmus. The procedures which can be done to treat nystagmus is we can do modified Anderson's procedure or Kestenbaum-Anderson's procedure.
Perfect, ma'am.
Okay.
Sweekriti, are you ready?
Oh, we go to the last question on the basic round.
Sweekriti, Mona, can you start your audio, please? Yeah, perfect, Sweekriti. Yeah.
Yes. So you are seeing the diagram and two responses. What is this test? Sweekriti, what is this test?
Ma'am, double Maddox rod test.
Very good. How is the test done? You're seeing the diagram. You can just describe what is in the diagram.
Ma'am, on one eye will put the red glasses, ma'am, and
Glasses or what? What will you put? You just now said, na, double Maddox rod. So you'll put a glass or a Maddox rod?
ma'am, Maddox rod. Sorry.
Yes. Yes. And then we go to the third question. How is the torsion measured? How is the torsion measured? You can see the patient is wearing the double Maddox rod on a trial frame. And so, how will you measure the torsion? Okay. Which extraocular muscle palsy will cause X cyclotorsion? Which extraocular muscle palsy will cause X cyclotortion?
Ma'am, superior oblique palsy.
Yes, very good.
Nice.
So go to the correct responses, please.
Yeah, so the test is double Maddox rod test. How to do it? We take two. I have seen only red Maddox rod. Here in India, probably we are not getting a white Maddox rod.
Yes.
So I put two Maddox rod on both sides. We shine a torchlight in front around 1 meter. So we ask the patient to look into the light. When the patient look through the Maddox rod to the light, he will see a horizontal line when the Maddox rod is vertical. He will get a horizontal line in each of the eye. And if there is superior oblique palsy, he will see the line, the horizontal line is little tilted. Okay, so the answer for this third question is, to measure the torsion, we ask the patient to get the two lines parallel with each other. So patient can actually touch the Maddox rod and tilt it, rotate it a little bit to make the two lines parallel to each other. They will not be together, but one and above, it will be straight parallel to each other. So that on the trial frame, you can get how much is the X cyclotorsion. You can measure it like 5 degrees or 10 degrees or more than that. How much patient has rotated it from 90 degrees to the opposite, the direction of the tilt. And the answer for the fourth question is superior oblique palsy, which is correctly answered.
So, do we, I think then we go to the seniors now with the second round.
Would you, ma'am, would you want me to skip these basic questions or directly?
Yes, skip them. We'll go to
Okay.
the.
Or ma'am, would you do a favor that can you just like read out the questions so that they don't miss on the questions?
Okay.
Yeah.
So anyone can quickly answer also, we don't mind. So this is the basic 8th question. What are these symbols? What are these tests used for? Anyone can quickly answer, then we won't wait. Which is the most commonly used test for visual assessment in a clinic for a pre-verbal children, which does not require a chart? Name 2 tests for preferential visual acuity testing, and when does fixation reflex develop? I can just I can just read out the answers now. Varda, is it okay?
So yeah, I'll just say that this is a Lia symbol. The assessment for pre-verbal, we do CSM, that is, we look for a fixation which is central or eccentric, steady, that means nystagmus is there or not, and maintained, that is the fixation is maintained or not. So this is the basic method of checking any child in the clinic. The third question is 2 tests of preferential visual acuity testing is Teller acuity chart and Cardiff acuity chart, and the fixation reflex develop at 2 months of age.
Okay, next. So what is, this is the diagram, and what is spiral of Tilo? Which muscles are attached, which muscle is attached farthest from the limbus? What is the arc of contact? And are oblique muscles a part of spiral of Tilo?
So
anybody?
Answers? Yes, answers.
Basic question. I mean, everyone should know this.
Ma'am, I'll answer. So this is the spiral, which is basically where all the recti are attached. The spiral made by the insertions, and farthest will be superior rectus.
Yes.
The arc of contact would be where the muscles are attached till the functional equator, and our obliques are part of it. No. So
yes. So perfectly answered, Rolina.
Not because I know them.
So this is the refractive error which is given. The child is wearing a +4 diopter sphere with a +2 diopter cylinder at 180 degree. So can anyone name this refractive error quickly? Whether this is with or against the rule? What is Sturm's conoid and circle of least diffusion? Which clinical condition can this refractive error present in? So answers, Varda, you can quickly give the answers so that we can move out.
Yeah, so this is actually very simple. This is compound hypermetropic astigmatism. This is against the rule astigmatism. And Sturm's conoid is just a representation how the rays are reflected through 2 different power meridians. So basically it is a parallelepiped which gives areas of least diffusion. So what is circle of least confusion or diffusion is the smallest cross section of the blur circle between the 2 focal lines formed by the astigmatic lens. So here in the figure you can see in D, you get a circle. That means this point you will have least confusion or diffusion. So everyone should read about Sturm's conoid, and the answer for the last question is that it can have an accommodative esotropia, clinical condition which with this condition can be accommodative esotropia with ambliopia.
Okay.
Can be ambliopia.
So with this, we go to the next round, which is the clinical round, which will be answered by Mitali, Dhruv, Shashwat, Samvedya, Samantha, right? So, Varda, can you ask the questions and I'll answer them.
Sure. So first question goes to Mitali. You can unmute yourself.
Yes, ma'am.
And look at the pictures given. And the first question is, which cranial nerve is paralyzed?
Ma'am, sixth cranial nerve.
Which one? Which one?
Which is the
Right or
closest-
left?
Yeah.
The left side, ma'am.
Yes.
So which is the closest differential diagnosis for this condition?
Duane's retraction syndrome, ma'am.
Excellent. Very good. So two important differentiating point between paralytic and restrictive squint.
Mm,
Like how will you differentiate between Duane's and sixth nerve?
Duane's will have a converging component to it.
Okay.
Try.
Converging.
So next.
Okay. The last question is, which is the surgical treatment done to improve the abduction in this condition?
Transposition surgeries, ma'am.
Yes.
Very good.
So, as you rightly said, Mitali, it is the left sixth nerve palsy. The closest differential diagnosis is Duane's retraction syndrome. The main difference between the paralytic and restrictive is, in the cases of paralytic, the deviation is always proportionate to the loss of movement. So if the patient can't move the eye from midline, he will have proportionately large esotropia in the primary position versus Duane's, where they may have a grade 4 limitation of abduction with absolutely no deviation in the primary position. And then Duane's retraction syndrome will have presence of retraction up and down shoot in restrictive squints. And then we do muscle transpositioning procedure to remove the to improve the abduction. Rightly said. Very good.
So the next question is for Dr. Dhruv.
Just do one by one, please.
Yeah.
One by one.
So the next
Sure, ma'am.
question, Dr. Dhruv, are you ready? So I'll give you a little more time to look at all 9 gaze picture and one more picture which is down. So if you look at all the ocular motility in all pictures, you will surely get the diagnosis. And the first question is, name the 2 extraocular muscles spared in this palsy.
Superior oblique and little rectus.
Yes.
Excellent. So the next question is,
Sorry.
which characteristic feature is typical of traumatic palsy of this nerve?
Aberrant innervation.
Excellent. The third question, which condition give rise to pupil sparing third nerve palsy and why? So this is the most common question asked, like pupil sparing third nerve palsy, which conditions and why?
Next.
Okay. So elaborate 2 features of nuclear third nerve palsy.
Ma'am, ptosis.
Nice. One more. Great.
Anyway, answers, please. Well answered, Dhruv, na?
Yes.
Yes. So it is obviously a third nerve palsy. You can see a complete ptosis, loss of adduction and loss of the elevation depression. The only muscles which are spared are superior oblique and lateral rectus, he rightly told us. Aberrant reinnervation, very well answered, Dhruv. Sometimes we are following up a patient as ischemic palsy, and then suddenly aberrant reinnervation comes, and it is because of trauma, or it could be because of a compression. So you have to neuroimage these cases. The pupil sparing, you should always know that it is seen in ischemic mononeuropathy, as in diabetes. And that the reason why pupil is spared, because the pupillary fibers are superficial and they get their blood supply from the bile vessels. Okay. Ptosis, the last part is ptosis. If it is present, then it is bilateral in a nuclear, because they have a common nucleus, and there's always a contralateral superior rectus which is affected in a nuclear palsy because it has a bilateral representation. So that is the answer. Okay, go to the next question, please.
So the next question is for Dr. Shaswat. This is going to be a little difficult. You can actually look at the central picture. What I'll say, this is a 9-gaze photos of a kid. Look at the central picture. So we'll move to the questions.
Have you had a chance to look? Otherwise, we can give you a few seconds again for seeing the pictures.
Or would you want me to narrate the questions?
I can narrate it. Like I have the slides. So we'll keep this picture. I'll ask questions one by one. So the first question is, name 3 components in this head posture. So look at the central picture and tell me what all head postures this kid has.
Name the 3 components.
Head tilt.
Yes.
To which side?
Head tilt towards right. Chin deviation.
It's left.
Head tilt towards left. Chin deviation towards the right. And
Chin deviation. Chin depression or elevation.
Okay.
Okay.
Anything
Yes.
else?
Anything
Very subtle.
Okay,
Turning
go to
is
the next question.
Yeah. So the next question is, name the test for checking X cyclotropia.
Next.
Discussed. Okay. Name 3 differences between unilateral and bilateral superior oblique palsy.
Yes. Attempt.
Anything between superior and unilateral and bilateral superior oblique palsy?
Okay. Next.
Okay. Name the clinical test to diagnose superior oblique palsy. Which test you do in case of fourth nerve palsy? Clinically.
Okay.
right.
So the 3 components in a case of fourth nerve palsy is, one is the chin depression, because it is a depressor muscle. So if you depress the chin, the eyes will elevate. It is an abductor muscle. So the face turn is on the same side and the head tilt is on the opposite side. So they have chin depression, face turn to the same side and head tilt to the opposite side. That is the compensatory head posture, which is very typically seen in the picture. We can diagnose fourth nerve palsy by doing a double Maddox rod test. Then in cases of unilateral and bilateral, in cases of bilateral, this head tilt test will be positive on both the sides. In both the sides, there will be an hypertropia of the opposite eye. In cases of bilateral, we have a V pattern present. And in cases of bilateral, objective torsion is more than 10 degrees. So that is the difference between unilateral and bilateral. And clinically, we diagnose this condition by doing a Parkes 3-step test. Okay.
So the next question is for Samvedya. Samvedya. So look at the picture. So that is pre-test and post-test. So the first question is, most sensitive test for myasthenia gravis.
Ice pack.
Yes.
Very good. So the next one is, which muscle is most commonly affected in myasthenia? in ocular myasthenia?
Medial rectus.
Very good. So what is the mechanism of tensilon test?
Injection.
Okay.
Okay.
I'll go to the next question. Name the treatment modalities for the same. How do you treat ocular myasthenia?
Immunosuppressants.
Yes. Something before that?
Pyridostigma.
Yes.
Correct.
So very well answered. That eyes test, it is about 90% sensitive test and can be done easily in the clinic and gives an answer to your differential diagnosis in the clinic. Medial rectus is the most common muscle involved. The edrophonium, the tensilon test, what we do is give an intravenous infusion of edrophonium, and which is a cholinesterase inhibitors, and it prevents the breakdown of acetylcholine and thus increases its concentration at the neuromuscular junction, and hence helps the muscle to act, and the ptosis and all disappears. And you've partially answered that we use pyridostigmine immunosuppressants. In kids, we might need to do thymectomy if the thymoma is there, and plasmapheresis. So these are the answers.
Try to answer a little faster to make it convenient for both of them. They are sparing their time for you. Okay, try to be a little faster.
So the next question is for Samantha. So look at the 9-gaze photograph of this patient. I'll give you few seconds more. So if you observe all 9 gaze, I'm sure you'll get the diagnosis. So coming to the first question, name the condition.
Samantha?
Yes, ma'am. Toan's retraction syndrome.
Very well.
Excellent. The second question is name the mechanism of its causation.
Yes, and there's a problem with the innervation.
Yes.
Very nice. The third question is what is pumpkin seed sign?
You're seeing it in this
Pass
picture.
that one, they won't know that. Yeah.
Yes, okay. Come to the next. Yeah.
The last question is name 2 syndromes associated with this condition.
Samantha?
Yes, ma'am.
Okay, so we'll go to the answers. It is a Duane's retraction syndrome. As she rightly answered, the main pathology is innervational along with mechanical anomaly. The pumpkin seed sign is a severe upshoot when cornea disappears under the lid, as was shown in the picture. And the syndromes are Goldenhar and Wildewang syndrome. Okay, can we now, what do we do, Rolika? Do we have more questions, or we can just skip them?
We can go ahead with ma'am this question.
Huh?
We can go ahead with this one. Yeah.
Okay.
So this can be answered by anybody. Whoever knows can take.
Pradeep has not answered, ma'am, I guess.
Identify the condition. Sorry, Varda.
So, if you look at the 9-gaze picture, so can you identify this condition?
Anyone?
Brown syndrome.
Excellent. Very nice. So can you tell me what is exaggerated force reduction test?
Hypotrophia in primary.
No, that is for the second, third. You're telling the answer for the
indication.
Anyway, we go to the next question.
Yeah, the third question is name 2 conditions for treatment. When to treat these patients. Just now you said you can try that.
Hypotrophia in the primary gaze.
Primary position.
Yes, and one more. Anyway, name the surgical procedure.
Yeah, name the surgical procedure of it for the treatment of this condition.
Brown syndrome comes as a question very often. So even like It came for us as a short question too.
So we go to the answers. So as he has rightly said, it's Brown syndrome or the superior oblique sheath syndrome, where they have a tight sheath of the superior oblique. The exaggerated force junction test is the eyeball is retropulsed in the globe, and we test the tightness of the oblique muscles, because if we don't retropulse them, then we will be testing the recti muscle and not the oblique muscles. So indications for treatment are presence of hypotropia in the primary position and presence of significant posture. The procedure is superior oblique loop tenotomy, the chicken suture, or superior oblique tendon spacer.
Which also was a class that was taken recently in the sessions, so two sessions back.
Okay.
And we'll go to the diagnostic part now.
Yes. Go to the diagnostic.
I'll send these questions to them for their convenience for it.
Okay. So this will be answered by the first year students. I'll be asking Anu will answer this question. Name the instrument. Anu, fast. We don't have to wait
you
for.
know this, guys. It's kept inside your CVI room.
Yes. Anu or Zeel, anyone can answer this question.
Synaptophone.
Yes. Name 3 uses for this instrument. Fast. Okay. Principle on which it works. Okay. What are the grades of binocular vision? I think you can answer this. Grades of binocular vision. Okay. We go to the answers, Varda.
Yes, so this is a synaptophone. It is used for measurement of squint, assessment of binocular status, and orthoptic exercises. Also used in amblyopia treatment. The principle is haploscopic principle. We dissociate 2 eyes, and the 3.
Basically, we are testing the fovea of 2 eyes, which means the haploscopic principle.
So this is basically test the 3 grades of binocular single vision. Those are simultaneous macular perception, sensory fusion with range, and stereopsis. So everyone should know about synaptophore thoroughly. At least these 3: simultaneous macular perception, fusion, and stereopsis.
Next question. Next question is for Zeel. So identify the test. Zeel, can you identify the test?
Anu and Zeel.
Quickly.
Anybody else?
So if you get questions, you will get the answer. Please read carefully.
Okay, this is a TNO test. What is the full form of PNO? What is the full form of PNO? Anyone? No? What is the disadvantage of this test?
I think Reshma answered that question. Reshma, say it loudly.
The Netherlands organization.
Yes, Netherlands organization. What is the disadvantage of this test? And name 2 more tests for testing stereopsis.
Stereo butterfly.
Yes.
Stereo butterfly test.
Any other?
Titmus stereo test.
Oh, okay. I think yes. Come to the answers, Varda.
So this is a TNO test, that is the Netherlands organization name of TNO. This test only for near stereo acuity, and we have different charts for distant stereo acuity also. The other 2 other stereopsis tests are Randot's and Lang's. We also have the Titmus flight test, which is commonly used.
Okay. So the next question. Next question goes to Ashita. Ashita, are you there? Yeah.
Right.
Can see this.
Please, Samantha, would you like to answer this, ma'am? Ma'am, I think they have some audio issue.
Okay. Anyone can answer this. Name the test and its principle.
Hess chart.
Yes. Hess chart. Yes. On what principle is it based? Anyway, what is comatization in a paralytic squint? What is comatization in a paralytic squint? In the above example,
Ashita, could you please fix your audio? The 2-3 people are sitting together, so it becomes very noisy. So try to please adjust the audio of the other one. Anybody else can answer till then, please?
in the above example, which eye you feel is paralytic?
Right eye,
Yes,
lateral.
very good. Which muscle is contralateral synergist to the paralytic muscle?
Left eye, member.
Yes, okay,
Correct.
good. So
So-
come to the answers.
Yeah, so I'll quickly go through the answers. The first question is the test and the principle. It's Hess charting, and it is based on again an haploscopic principle. So the second question is clinical condition. Sorry, second question is comatization of the paralytic squint. That is in chronic cases when the deviation becomes equal in all direction. This is called as comatization of the squint. Matlab almost it looks equal. And third question is which eye is paralytic? Look at the smaller square. So you can see here the right square is little smaller. So this is a right lateral rectus paresis, and the contralateral synergist to the paralytic muscle, which correctly answered, that is left medial rectus.
This is often kept as a spotter in your exams. So
Yes.
like you not just for OSCE purpose, for in general, it will definitely come in MS exams also.
So the next question is again based on the Hess chart.
Mitali, would you like to take it?
Who will take?
Mitali.
Mitali. Okay. Name 2 underacting muscles in 2 eyes. 2 underacting muscles in both the eyes.
The superior oblique muscle.
Yes, very good. Which clinical condition would such a palsy produce? Both the superior oblique palsy in both eyes.
The pattern, ma'am.
Yes, very good. What finding on ophthalmoscopy would confirm this palsy?
The position of the macula, ma'am, from the disc.
Fovea, not
Fovea.
macula.
Yes, ma'am. Foveal reflex.
So excyclotorsion on the fundus. Which is the common cause of this condition? Bilateral superior oblique palsy or bilateral fourth nerve palsy?
Trauma. Head.
Okay. So just she's given the most of the answers correctly. Just quickly.
Yeah, Mitali, your all answers are correct. This is bilateral superior oblique muscles are paralyzed in this Hess chart. It causes V phenomena. Excyclotorsion can be seen on fundus, and most common cause being closed head trauma for bilateral superior oblique palsy.
Okay. So yes, so this is the 5th question on the diagnostic round. I think this can be answered by the juniors. You are seeing various equipments. Name the test and its purpose. What is the test? What is this test and what do we do it for?
Surumi, you want to answer?
A prism test, ma'am.
Prism?
Prism test.
Prism test. Make a complete answer. Okay. So what are the 3 prerequisites for this test? What are the 3 prerequisites for this test? Okay. Which is the direction of the base of prism when we are measuring an exodeviation? An outward deviation, where do we keep the base of prism? Okay.
Base.
Base, yes. What are the effects of high plus or high minus glasses on measuring the squint? I think we have to go to the answers.
Okay, so the first question is what is this test? This is a prism bar cover test or alternate prism cover test?
You can't say prism test, huh? You have to be complete in your answer.
Yeah. So the prerequisite for this test is patient should have a very good vision, at least some vision to fixate. So ideally it is 636 we say on Snellen's chart, that at least patient should have a target to fixate. Then only I can do this prism bar cover test. They should have a central fixation and the eye should have good motility. At least the eye should come till the center. Then only I can do this alternate prism cover test, or PBCT, what we say, prism bar cover test. While measuring the exodeviation, we keep the base in. So the apex will be outward and the base will be inside.
Remember the mnemonic, apex in the direction of deviation. So whenever we are measuring, apex in the direction of deviation. So then you will not get it wrong.
And what the high plus and high minus number will have some effect on the measurement. High plus will have a lesser measurement, while high minus will overestimate the angle.
In both ESO and EXO. Okay. So the sixth question, who will take it?
Reshma, do you want to take it?
Reshma. Yeah, this test is done without an occluder. So you name this test and the principle. This doesn't need an occluder. Reshma?
Ma'am,
Yes, yes, very good. Very good. And its principle is based on what? Okay, which condition is it done in?
Poor vision patients.
Yes. What is the range of normal horizontal vergence? It should be. Actually, I corrected, but I send the previous this to horizontal vergence, normal horizontal vergence. And which patients have large vertical fusion, Reshma? Large
In congenital SO palsy.
Yes, very good. So answers quickly.
Yeah, so answers are, this is Krimsky's test. The principle is prism reflex test. So as I told you that the vision should be good for first prism bar cover test. If it is poor, we'll do Krimsky's test. So second is when it is done in patients with poor vision, and what is a normal range of horizontal version is around 35 to 40 degrees we can converge, and divergence it is 5 to 7 degrees. So the fourth question, patients having large vertical fixation, correctly answered, that is in patients with congenital superior oblique palsy.
Next question.
Ma'am, would you like me to switch to a management part, or you would like to continue with that?
The seventh question will take in this round.
Yeah, because this is quite important.
Yes. So, who will answer? Muskan? Kirti? What is the long form of this instrument? Can you identify this instrument and its long form? Anyone?
This is a very favorite question for your Viva. Everybody's going to give this to you and ask you.
Okay. So it is an RAF rule. We'll come to the answers later. What are the types of convergence? Can you answer? What are the types of convergence? Anyone? What is normal near point of convergence? And what is convergence insufficiency? Okay. The answers.
Yeah, answers are, these are RAF. This is an RAF ruler, that is Royal Air Force rule measuring convergence and accommodation. Also, we use it. So the types of convergence, it can be accommodative, fusional, proximal, and tonic convergence. Normal range is 8 to 10 centimeters, and convergence insufficiency is like when the convergence is deficient, it causes difficulty in near work, and a lot of patient comes with reading problems and headache. So you should always check for this convergence insufficiency in all patients in OPD coming with headache.
Okay. So now
which ones do you want me to go to?
Management. Go to the management now. This is the Parks 3-step test. Okay. Yes. So Varda, read out the question.
So I think final year can answer. First question goes to Mitali. That is which injection is given in this procedure?
Ma'am, Botox.
Yes, very good.
Really good. How does this injection work?
Chemical degeneration, ma'am.
Very
Yes.
nice. So name 2 conditions in which this injection helps.
Next.
Okay, what is the limitation complication of this procedure? When do you give Botox?
When there is a paralytic.
Okay, we'll come to the answers. So as rightly told by her, this is injection botulinum A, which is synthesized by Clostridium botulinum, a neurotoxic protein. It acts by causing chemodenervation of the muscle in which it is injected. So we use it in the paralytic squint, but in the contralateral synergist muscle. So if it is a left lateral rectus palsy, we give it in the left medial rectus so that the eyes remain straight. And in cases of infantile leso also, we use it in the medial rectus. The disadvantage is it has a limited effect for few months and surrounding muscles also can be affected. So when you're giving it for lateral rectus palsy, you can end up having a ptosis. Next.
So coming to the second question, this can be answered by Dr. Dhruv. So look at the pictures. And can you name the surgical procedure done in this picture?
Farden procedure.
Excellent, excellent, very nice. What type of suture is used in this procedure?
Non-absorbable 60.
Excellent, very nice. And what is the principle of this procedure?
Recession of the muscle.
Yeah, but what is the principle? Why we put that suture there? This is not normal recession.
Yes, ma'am.
Next. Okay. The last question is, what are its indications?
DVD.
When do we do Faden?
Yes, DVD. Yes, very good. So come to the answers. So basically, this is known as retroequatorial myopexy or Faden. So we are fixing the muscle behind the equator. That is retroequatorial. As you said, it is non-absorbable. How does it work? It can be combined with recession. It's not always combined with the recession. It can be done without recession also. The muscle is sutured to the globe behind the arc of contact and hence shortening the lever arm and reduces the action of the muscle specifically in the direction of its action. So if you are applying it to the medial rectus in a 6-nerve palsy, it will not affect the primary position deviation, but reduce the action of medial rectus on the in the adduction. And it is again, as rightly said, used in dissociated vertical deviation, infantile esotropia, nystagmus blockage syndrome, and convergence excess esotropia. Next.
I think we'll complete like 3 questions more for the 3 students.
Yes, sure.
It's already 9. So the third question goes to Shaswat. Look at the picture. Can you name the procedure?
Recession.
No.
Something to the recession.
Something we have done extra.
More. Next.
Adjustable.
Yeah, excellent, excellent. So this is adjustable suture. What is the advantage of doing this procedure?
We have a better alignment.
Yes.
Because
Good.
of the procedure.
We can adjust it. So that's advantage for the patient. And which are the conditions where this procedure is indicated? Which are the conditions?
Next.
Okay, I'll go to the last question. What are the types of adjustable sutures? Different types of adjustable sutures, you know.
We come to the answers. So as you said, it is a adjustable recession surgery. We are doing a recession, but we are adding one adjustment to it. So it gives an additional hand in achieving a good binocular alignment. Indications are resurgery, where we have limited muscle and the scope for mistake is less. We have a large angle deviation where we cannot assess exactly. Concomitant squints with diplopia where we want an exact result, and dysthyroid myopathy. So the two as shown in the diagram, one is sliding nose technique and one is the bow tie technique. Okay, can go to the next question.
So next question to Samvidya. So look at the picture. So can you name the muscle to which suture is applied?
Inferior oblique.
Excellent. So overaction of this muscle causes which anomaly?
The depression.
Okay. Third question, from where does this muscle arise? This is a first year question.
Annulus of Zinn. No.
Inferior oblique.
From the.
Sometimes the simple ones can confuse you. Yes. Next.
So the last question is, name one procedure of selective weakening of this muscle.
Anyway, we go to the answers. So this is very well answered. Inferior oblique muscle. If there is a how the overaction will present if it is unilateral, it will cause ipsilateral hypertropia. If it is bilateral, it will cause V phenomena. It originates from the orbital floor just lateral to the nasolacrimal groove. And selective weakening is the anteropositioning. Selective procedures are where we just treat one component. So if you want to reduce the elevation effect of inferior oblique muscle, we do anteropositioning. So that is the selective procedure. Okay. Next.
So coming to the last question to Samantha. Sorry for the spelling mistake in this slide. The 1-year-old child comes with the esotropia. Child has freely alternating fixation and a normal ocular motility. So the question is, what will you do first when the child comes to you? Samantha?
We perform extraction after using a cycloplegic.
Correct. So
with cycloplegic at 1 year of age? Be more specific.
Homatropine?
Yeah. No.
Okay. Next.
Okay, fine. The next question, if this test is normal, what would you do next? What will be your advice? If the refraction is normal, like not so high, so what is the next advice will you give to this child, 1-year-old with esotropia?
Surgical correction may be required.
Yes. Surgical correction, she said. So that's good. So the third question is, later on, which complication can occur in this child? Like once you do the surgery.
BVD.
Excellent, excellent. That's really good. And the last question, which is the most commonly done surgery in this condition?
Medial rectus recession.
Very nice, Samantha. Very nicely answered this question.
So go to the answers, please. So refraction and fundus has to be done under atropine whenever there is a esotropia and the child is less than 4 or 5 years of age. You can't use homatropine or cyclopentolate. You have to use atropine. Surgical correction before, if the refraction is normal, what advice would you give? It has to be surgical, and you have to correct the squint before 12 to 18. It's not 8, it's 18 months of age, so that the child gets a good binocular vision. Later on, the child can develop dissociated vertical deviation and inferior oblique overaction. And the best surgical option is bilateral medial rectus recession. Okay. So we finished with the, can we do 4 or 5 rapid fire?
You would like to, ma'am?
Sure. Or is it late? So we can just pass on the questions.
As you say, ma'am, your choice.
If we can go for 5 rapid fire.
So, ma'am, we'll do one thing. We'll have the final years to just
Okay.
quickly.
Final
the
years
rapid fire.
have rapid fire. Yes.
Mitali.
So, Mitali, I'll read out the questions.
Yes, sir.
Okay.
With regards to extraocular muscle, which statement is least likely to be correct? All rectus muscle arise from annulus of Zinn. Ciliary ganglion lies between lateral rectus and optic nerve. The inferior oblique muscle passes between the globe and the inferior rectus. The medial rectus inserts an average of 5.5 millimeter from corneal limbus. Quick.
See, ma'am, inferior oblique does not pass.
Correct. She gets it right. Second.
Samantha. Achha, five for her, ma'am.
Mithali ke baad Dhruv. Dhruv. Which one of these combination of muscle constitute a yoke pair? Right superior rectus, left inferior oblique. Right superior rectus, left superior oblique. Right superior rectus, right inferior oblique. Right superior rectus and right superior oblique.
A, ma'am. A.
Yeah.
A. Very good.
Excellent.
Right superior rectus and left inferior. Yes. So in the third one, in hypermetropic anisometropia, anisoconia, that is the difference in the size of images, can be reduced by one of these methods, decreasing the distance between spectacle lens and cornea. Shashwat, yes. Increasing the front curvature of spectacle lens without changing the power. Reducing the thickness of spectacle lens without changing the lens power. Using high refractive index.
Ma'am, A.
Correct. Very good. Good. They're answering good. So now Samvedya, the following statements are false about isolated fourth nerve palsy, except head trauma is the most common cause in children. Aneurysm is common cause in adults. Head is usually tilted towards the palsied side. Congenital form tends to have large vertical fusion range.
Ma'am, D, congenital form tends to have a large vertical fusion.
Sorry, you've missed it. The answer is
D.
Head is tilted towards the.
No, ma'am. Correct.
Oh, sorry. She's right. She's right. D. I got confused. It is false. Yes, you're right. Yes. So, patient has a white Maddox rod over right eye and a red Maddox rod over a left eye. So, see the response above. It could be right orbital floor fracture, right fourth nerve palsy, left fourth nerve palsy, or left thyroid eye disease.
Samantha, this one's last one's for you.
Samantha?
Yes, ma'am. Right fourth nerve palsy.
Correct. So it's 100% in the rapid fire.
They were listening to you because all of these questions are a part of what you have taught already.
Okay.
I think final years, Mitali, Dhruv, Shashwat, Samvidya, and Samantha are like really good.
Yes.
Congratulations, you have actually answered most of it, and you can set an example for the first year. First years can gear up for their studies, and you can take their advice how they are studying. So they are doing actually very good. All the best for your exams.
All of you can turn on your videos.
Yeah.
Thank you so much, Shubhangi ma'am and Varada ma'am. You have actually spared your time on Diwali day. And it really means a lot to us, to all of us, and to the iFocus team also. And the postgraduates are extremely happy to see all the questions. And I think they've missed few questions which we will share with them. And thank you to the postgraduates for sparing your time. Some of you are at home, some of you are at work. So great. Thanks a lot for your contribution today. And thank you, ma'am. Would you like to say something, ma'am?
Yeah, this is a very interactive platform and a very good platform for postgraduate learning. And I'm amazed at the amount of lectures you have and the depth in which each and every subspecialty is covered. hats off to Dr. Santosh and your team at iFocus on doing this on a weekly basis. I must congratulate the team for doing it so well.
Thank you so much.
I tend to attend the lectures whenever I can. So, very good.
Yeah,
Keep
thank
it
you, Dr. Rolika, for like conducting this so well. Thank you,
Yes.
Dr. Santosh, and
I
iFocus
didn't do
for this
anything.
opportunity. And I'm really happy with the response of the postgraduates. They're actually very interactive, and I had a lot of fun today. Thank you so much.
And that too on a topic which is which most often goes beyond our understanding. So great job,
Try to
guys.
keep the difficulty level to moderate so that people don't lose interest in.
Absolutely, ma'am. Thanks a lot, everyone. Thank you so much. And the next session will be on October 26th. That will be October 28th, sorry. That will be the exam special, the short cases in Strabismus by Dr. Nina. So I recommend that all of you turn up for the short cases also, because these cases are very often asked to you, and you won't imagine the discussion that you have. All of these bits will be useful for you in your final exams. So thanks a lot, everyone, and a very good night and a happy Diwali to all.
Happy Diwali to everyone.
Happy Diwali.
Bye.
Thank you, ma'am.
Yeah, so leave now.